The first thing is really to quickly identify the stroke, have an expert in identifying the clinical presentation of stroke recognize it early on, obtain rapid imaging to verify that one of the large blood vessels to the brain is in fact closed off, likely by a clot. If that happens and the patient is a candidate and the patient is not improving and we all feel that the patient is at risk for having a neurologically very serious impediment as a result of this stroke, we would mobilize the team and quickly obtain a cerebral angiogram. So that's the catheter angiogram. And if that verifies that there is a closure in one of the major blood vessels, depending on when the patient arrived, we would have several options open to us. On the adult side, what most centers are doing is if the patient arrives before 6 hours have passed from the onset of symptoms, and we are now before hour number 6, we can try to put a microcatheter directly into the clot and inject very small amounts of TPA directly into the clot. The advantage there is that because we're injecting directly at the site, we get a very high concentration of the drug locally and a very low concentration elsewhere, so that the global bleeding risk that one has from intravenous TPA is not there, or is much lower, whereas it can be much more efficacious locally because it's a very high dose. That will likely be the first thing we will try in almost all cases. If that is not successful, there are a range of mechanical devices that are available to try to extract clots. The first generation of device can best be described as a specialized corkscrew that literally passes through the clot and engages it, and then is designed to pull the clot out, sort of whole, into the guide catheter and then out of the patient. There are a new generation of devices that have come. One of them is available already, which is more of a suction catheter that's designed to break up and macerate the clot from the back and suck it out into a suction system. And there's a new generation of devices coming that are designed to open up a tube within the clot and sort of immediately create an open blood vessel and eventually allow the clot to be absorbed by the body once it's fragmented, instead of trying to actually extract it. All of those are potentially open to patients, but a lot will depend on the age of the patient as well, because one of the technical challenges in working in children is that we're constrained by the size of the blood vessels. So for example, some of these devices require a fairly large guide catheter to contain the device. On the adult side, one can put a very large catheter into the leg without a problem. Once we start getting down into the young children, the risk of permanently damaging one of those arteries by trying to put a very large catheter in becomes unacceptably high. And when you get to infancy, it's not even possible to put a large catheter in. So we're a little bit constrained in the range of devices we can use, but increasingly they're available in and smaller versions, and I would expect that we will be able to offer a fairly wide range of potential options, again, assuming the patients arrive quickly. That's really the bottom line.